Thank you so much for joining us on this session. And we are discussing something which is quite prevalent in women. Breast cancer is something which is from the 1990s, it has come up from fourth position to the first position in women. Uh, in India, 14% of all cancers in women are detected as breast cancer, to the state that every 4 minutes, women is detected with breast cancer in India. So that tells you the magnitude of this disease and the sudden rise which it has taken from the 1990s to this day. Now I have with me three panelists. We will speak about the foremost and the most important thing about breast cancer, which is the screening of it. That is the first step, and probably that is the most important step. So I want to start with you, Dr. Kaur, and I want to understand what is the current situation when it comes to breast cancer in India? What are the prevalence level which are there in India, and how are we fighting it currently?
So that's an entire day. You correctly mentioned breast cancer prevalence is at an all-time high actually now. And in fact, data suggests that it has almost doubled from 1985 to now. Breast cancer incidence in India has almost doubled. The problem with breast cancer in India, and I know we are going to be talking about screening, but in India, screening we have to talk about in a very different context. We are not talking about picking up cancers when they cannot be felt or don't have symptoms. We are talking about downstaging the presentation. So rather than a woman coming with a 7 centimeter fungating lump, which is what 70 to 80% of breast cancer presents in stage 3 and stage 4 in India, which is a very sad scenario. Also, another very sad fact with breast cancer in India, when we talk about prevalence and incidence, is that we see a very high number of young breast cancer patients as opposed to the West. So whereas in the West, breast cancer peaks in the 5th and 6th decade, in India it peaks a decade earlier, in the 4th and 5th decade. Also, whereas in the West, 6% of all breast cancers happen in women under the age of 40, in India, the number is believed to be as high as 16%. So I'm sure my worthy panelists, end up seeing a lot of girls in their late 20s and 30s with breast cancer. So that is sadly the current situation of breast cancer in India. We are picking it up late. There is no standardized screening as yet. And sadly, there is no standardized treatment modality as yet. So that kind of muddles up the entire landscape of breast cancer presentation and treatment in India.
Right. Dr. Dr. Kaur mentioned that we are picking them late, and also younger women are getting diagnosed with breast cancer in India. Why do you think that is?
So first is, she mentioned around 16% less than 40. If you further subdivide and if you come to urban areas, around 50% are less than 50 years of age, which is quite disturbing. You said why younger age? We really don't have any study which proves that. But I believe, and it is not only breast cancer, almost all the cancers in India are peaking at almost a decade earlier as compared to our Western counterparts. Reasons could be many, but I believe it is increasing pollution, food adulteration, indiscriminate use of pesticides, and possibly rising stress levels. So these are my thoughts about why younger. Now the second part that you asked is why late diagnosis. Multiple reasons. Foremost is lack of awareness. And as was discussed in the previous panel also, it is not only the patient or the general public who is not aware. At times they do go to doctors, but they are told, okay, this is a small lump, this looks benign, and you can just follow it up, maybe a screening after a year, when actually that lump should be investigated further. So an awareness amongst our fraternity is equally important. Apart from awareness, neglect. People know about it, but they think it is not breast cancer. They think that their working for family or working for their career is more important, and this can wait. Also neglect by the society. So there are multiple reasons why they are coming very late. Sometimes facilities are not available, they are not close by, so logistic reasons. They have to travel far off to get them screened or get them tested, or travel repeatedly. So these are the issues. A biopsy has come negative, but I have a suspicion. I will recommend a repeat biopsy. Patient may not undergo that.
Right. You also mentioned that among your own workforce, and I was reading a study which said that even the paramedical workforce, they are not even aware about the breast cancer and the detection part of it, or getting the screening done after a certain age. So, what are your views, Dr. Pragna, on the aspect that less awareness and the younger women getting diagnosed with cancer?
I would resonate with what Dr. Kabra just said, that predominantly lack of awareness is because nobody, first of all, we have quite a high number of uneducated people in this country, though the numbers are increasing right now. So they don't really understand what the prime symptoms and signs are of breast cancer. And, but even that part is improving, because a lot of on breast cancer awareness days, etc. A lot of things are being conducted where people are trying to spread awareness on it. So the awareness is quite low. And about the counterpart, I just wanted to add that I totally understand that, because I have actually faced quite a few patients in the last couple of months who have been diagnosed as something quite different, but clinical suspicion pushed me to go ahead and get more biopsies. And so many of them are between the ages of 30 and 40, especially those who have been breastfeeding and who have been neglected or wrongly diagnosed, right? So on that part, I agree with Dr. Kabra that we should be aware of which doctor should be treating these patients, and the patients also should be aware of the signs and symptoms before anything else, before we even talk about screening.
Right.
Can I just add something here to that? Sorry. So, she did mention how about education levels in our country are low. But sadly, we see the most advanced cancers sometimes in the most educated women, because they ignore. And I have, in the past 1 year, seen more fungating advanced cancers in educated working women, some of them professors in colleges. And what I have realized, that the awareness that we are increasing, we see village women coming immediately because they heard on radio that a lump could be a sign of cancer, so they want to get it checked out. An educated woman will go on Dr. Google and Dr. WhatsApp to find out. And sadly, that is why we are picking up more advanced cancers in more educated women.
Absolutely. So I distinctly remember two examples. One in Delhi, editor with a leading news daily, who had a breast lump, fungated, and came for diagnosis or came for help only when she had back pain, when it had already spread to spinal column. And this was when her sister-in-law also suffered from breast cancer. She thought it is tuberculosis and doesn't need treatment. The other one is an English teacher, again came at a very late stage. Both of them succumbed. So
Right.
if we are talking of breast cancer awareness, if you go to certain parts of India, they would not even know what cancer is.
Right, right. So, Dr. Pragna, you said that, Dr. Kaur mentioned that, the stack is around 16% when it comes to women between the age of 30 and 40. And you said that you've been witnessing more cases recently. So, you think maybe there are more cases than the data would suggest? Do you find that?
Yeah, I believe that there are a lot of the numbers are increasing drastically. So what we see on the outside are only those people who actually come reported with a diagnosis of breast cancer and someone caught it and the data has been collected, right? So the actual numbers are definitely higher than that. And if you actually, Dr. Kaur actually mentioned this point earlier, that it has doubled since 1985, the total number of breast cancer cases. But even just between the age groups of 25 and 40, the numbers have drastically doubled, like doubled or even more from the 1980s to now. So that is something that's really concerning.
So when I talk to doctors about breast cancer, they always tell me that the 40 is the age when you should regularly go for detection in women, and there are more prominent cases after 40 only. So, Dr. Kaur, let me address this to you. Can you tell us the type of tests which one can go through for breast cancer, and how often, and is there any that slab of age where where one should take or one should not take, like 40 से बाद में ही करना है, ज़्यादा prominent तभी होता है? What are your views on that?
So, even as doctors, I don't think we agree to the right interval of screening and the right age at starting screening. So, let me just break this down. So, what are the kind of tests that are available? The gold standard worldwide for screening means doing a test when you do not have a problem, which means picking up a cancer before it creates symptoms. And that is when the likelihood of cure increases, because you're picking it up at stage 0, stage 1. And that test is a mammogram. A mammogram is an X-ray of the breast, which in the UK on the NHS used to be recommended from age 50 onwards, once every 3 years. They brought the age down to 47. In the US, they used to recommend it every year, starting from the age of 40, but then some guidelines changed and they said that it should be done once every 2 years and should be started from 45. So there is no hard and fast rule here. But in India, because we do see cases from the age of 40 onwards peaking, we recommend that screening mammogram start at the age of 40. But there is a huge caveat here, and we must understand that a screening mammogram should only be done in a standardized screening center. Otherwise, it can cause more harm than good because of 2 reasons. One, Indian women have more dense breasts than the Western counterparts, which means that the mammogram appears more white. Cancers also appear white, and the chances of missing a cancer on a dense mammogram are more. So, think of a woman who felt a lump in the breast or who just routinely went for screening. It gets reported as normal, but there is actually a lump in that breast that has been missed. So that mammogram is more harmful because the woman thinks my test was normal, so I'm okay. So ideally, mammograms, which are screening mammograms, should be done in units where there is a breast specialist service available, where there are breast-trained radiologists, because if we pick up, say, a 3 millimeter or a 4 millimeter lesion, then there should be a trained radiologist who should be able to biopsy that for us. Otherwise, you're causing more harm than good. So a screening mammogram done once every year or once every 2 years depends on the personal preference of the doctor who's recommending, the patient's personal history, the density of the mammogram, and a lot of other factors. Ultrasounds, a lot of people are looking at whether ultrasound can be a modality for screening in the community, and coupled with AI, whether that can kind of replace mammograms. It's not a gold standard as yet, not at all, but definitely something to look at. Then for those who have a strong family history or are gene positive, MRI scans, which are contrast MRIs, are recommended. Now sadly, what happens in India? A woman feels a lump in the breast, and the next test she gets recommended is a PET CT scan, which is not the test to be done for screening for the breast. So a mammogram, if there is an abnormality on the mammogram, an ultrasound, and if the ultrasound thinks this abnormality is not right, then we do an ultrasound-guided true-cut biopsy. This is the gold standard for testing. But because in India, we are, I think, miles and miles away from having that dream screening center, I would go with your own hands. They are the best screening tools, even in countries which have a formalized screening program in the community. They also see a significant number of what they call interval cancers, which are cancers that are picked up between 2 screening mammograms because the woman was alert enough to pick up a small lump.
So, Dr. Pragna, tell me, how do you detect that with the self-examination, as they call it?
So recently there was a study that was published, a 20-year-old analysis of a study by Tata Memorial Hospital, which showed that in women about the age of 50, there is a significant, significant mortality reduction when clinical breast examination is done every 2 years, right? And because, like Dr. Kaur mentioned, mammogram with a good dedicated ultrasound breast radiologist is a long way to go for people actually to reach that clinic. So till then, what we advise all the women in our clinic is at least keep examining your breast regularly, and then every 1 year, come to your doctor or your trained nurse. In this study, they say that at least trained nurses or trained personnel can examine the woman's breast, so they will understand if there's something wrong, so they can be suggested for the next imaging. So what we suggest today is that every 1 year, the woman comes to the hospital, gets examined, and then goes back home, if in case they don't have access to a mammogram, or at least these local centers where they can just examine and then send them home. But again, like it was mentioned earlier, although we don't have some particular guidelines that we follow today for screening, we would suggest women about the age of 40 to start off with a mammogram. These are average risk women.
Right. Dr. Kabra, Dr. Kaur was speaking about the gold standard method, which is mammograms. But we have a very scarcity of mammograms in our rural areas, even in our urban areas when compared to the amount of stack of breast cancers that we are seeing. And also there are, recently there have been detection methods through blood tests, which detects the tumor cells. So what are your views on the scarcity of mammograms in India, and also what are your views on the blood test which is available for detecting breast cancer?
It is not only scarcity of mammogram, it is scarcity of good mammogram also, as she mentioned. Having said that, we have to find a middle path. If we have a good mammogram center, not necessarily attached to a good breast unit, I think that's also okay, because a good mammogram center would at least know where to send the patient and how to guide the patient. All mammograms, all ultrasound screenings, MRI screenings have to be accompanied by a clinical examination by a doctor. That is very important. And you asked about 40 years of age, and we are seeing younger patients what to do. So apart from the mammogram, which is a test, a lady must become breast aware at the age of around 20-25. Start self-examination there and then. Also start clinical examination maybe every 2 years or so at that time, and then go on to tests. Now you're talking about blood tests being available. Blood tests firstly are not yet the standard of care. Yes, there is one test which is CTC, circulating tumor cells, has been now approved by FDA as a screening test by one of the diagnostic companies, but is not yet recommended as standard of care. One, it is not widely available. Two, and it is going to be more expensive, much more expensive. We are talking of rural India. You can't offer a test which is going to be more expensive as compared to mammogram. So practical utility of that test currently, no, not in India. We have to probably ensure more awareness, more self-examination, more clinical examination. That will do way more service to our population than introducing blood tests and its implications. So you're talking of blood tests. There is another test being studied for breast cancer, for other cancers, called precision risk score. Not yet in clinical use, but a lot of research is going on, quite promising. But again, you see, you are subjecting people who are not having cancer, probably not at high risk of cancer, to a genetic test, very expensive test. And there are a lot of implications, quality implications. At what age do you start? If you are asking a child or who is not yet an adult to do it, are you consenting on his or her behalf? Is the child willing? What psychosocial impact will it have on the child? How will the person, whether a child or an adult, be discriminated based on the test results? Insurance companies may refuse to give insurance. Employers may discriminate. Colleagues may discriminate. So there are lots of issues around these tests. And we have to be very, very careful before we really adapt them. They have to be robust. The quality assurance has to be there. We don't even have a quality assurance of a mammogram. Right.
Let's talk about the treatment variations which have happened over the course of years. Dr. Pragna, what do you reckon, what advancements we have made when it comes to treatment variations for breast cancer?
So back in the day, during the Halsted era, obviously we used to remove it used to be debilitating, removing the entire breast, the underlying muscles, etc. So it was quite hard for the patient to recover post removal of all that area. But now, not only is it a mastectomy, which is the main surgical option, but we also have other options such as breast conservation surgery, which only if it's obviously deemed safe by the oncologist. And besides breast conservation surgery as such, which is basically preserving the breast and just removing the tumor tissue with a good margin, today even oncoplasty, which is basically a plastic reconstruction of the area using either implants or using local flaps, etc., to reconstruct the breast. This is, of course, in keeping in view cosmesis, right? So breast conservation surgery is also found to be, with reconstructions, also found to be safe. And even with concern to the axilla, which is the armpit, right? We have to stage the disease by doing a particular kind of surgery. Earlier, it used to be removal of all the nodes there, and that was quite debilitating with side effects also. But today, with recent advances such as sentinel node biopsies and ICG, there's bare minimum surgery that we even perform there. There is de-escalation from the beginning, and it is going on. Hopefully, the surgeons don't get replaced by no surgery at the end of it.
Right.
Can I quickly add something here? Sorry. So, we talk of screening and we talk of picking up cancer early. But what, I have realized, and I'm sure they'll agree with me, is that it's not the fear of cancer that keeps the patient away from the doctor. It's the fear of treatments. So, the moment the patient comes in, the first thing they say is, "Meri chemo to nahi hogi, mere baal to nahi jayenge." That is the first question we almost always get asked, even before, will I survive this? So, when we talk to the community at large, I think when we are talking of advances in treatment, this message needs to go out loud and clear, that treatments have significantly, improved. And the earlier you pick up cancer, the lesser the treatments, the better the chances of success. And so many patients nowadays with breast cancer go through treatments without anybody in their family or friends even coming to know that they're having cancer treatment. And I think once that kind of an impression goes out in the community, more women are likely to then come forward and get their tests done in time. Otherwise, however much we talk about screening, at the end of the day, we're talking of cancer getting picked up, which will keep a lot of people away from getting these tests done because nobody wants cancer to be picked up in them. So those advances in treatments that she's talking about with respect to surgery have also translated in chemotherapy and radiotherapy and targeted therapies and immunotherapy. So cancer treatment has come a very long way.
Just to add to that again, I am obviously biased because I'm a surgeon myself, but besides the chemotherapy aspect, so besides the aspect of just chemotherapy, which is obviously the first question that everyone asks us, the other main point is, will I lose my breast? I don't want to walk out, without having a breast. How would it look in the community? So the other message that I would actually put forward is that, again, you do not have to lose your breast, and even if you do, right, there are ways to reconstruct it, especially in the younger women.
And also because the myths around cancer coming back if you save the breast are so high, that I sadly had to do a breast removal surgery 2 days ago in a 39-year-old who had an 8mm cancer picked up on a screening mammogram, who absolutely refused to save the breast because in the community the message was that whatever the doctor is saying, it's going to come back if you save the breast. So then we also, when we are talking of dispelling myths, I think this is also a big myth that needs to be dispelled, because we may sit here and feel very proud about our breast saving techniques and our oncoplastic techniques, but if at the end of the day the patient wants just a total breast removal to be, at peace in her mind, I think that kind of education also needs to improve.
Absolutely, we have all had such stories, and not only patients, but their referring physicians. And sometimes the lady will sit quiet, others are deciding what treatment is to be done. So we have to be very mindful. I always ask, you tell me, and sometimes I just tell them to go out and then talk to her.
Here.
So that's something which needs to be, when I was sitting in the previous panel, I got a message from an old patient of mine for his friend, breast cancer surgery हो गई डॉक्टर साहब, कीमो रेडिएशन ऐसी जगह बताइए जहाँ बाल नहीं जाए. So, that's what Dr. Kanchan just mentioned.
Right. So what are the challenges when it comes to our healthcare sector and, addressing the elephant in the room, screening and getting the screening to tier 2 and tier 3 cities and the rural and remote places? What are the challenges that the Indian healthcare system face when it comes to getting more mammograms in there? Do we need more active part of government in this, and or the private sector itself. So what are your views, Dr. Kabra?
So of course, before I come to mammograms, government has a big role to play in increasing the awareness. We are the IT capital of the world. During COVID times, we developed a very beautiful app, and we all heard the ringtones, very nagging ringtones, continuing. You have to hear them out for a minute before you get connected. Those things, maybe not that long, but those things can be used to give health messages, other health messages. So this can increase the awareness. Of course, availability of mammograms, availability of people who are trained to read it, and availability of people who are trained to treat breast cancer is a must in tier 2 and tier 3 cities, and it has to come. You cannot keep it concentrated at one level, and that is where also the role of primary healthcare center comes in. Primary healthcare center is delivering primary care. They should be made aware, they should be empowered to deliver counseling about good lifestyle and about screening. They can sensitize, because primary healthcare people have a better connect with our population. Second thing is, all tier 2, tier 3 cities, most of them would have a medical college associated or a district hospital associated. We have a facility. We just need to upgrade it. So a lot depends on how our government takes it seriously for development of cancer facility.
So I'd like to add to that. The government has a huge program called the NCD program, which is the non-communicable disease program, which looks at three main things. It looks at hypertension, it looks at diabetes, and it looks at cancer. So I've been trying to work in the community with the primary healthcare workers, the ANMs and the ASHA workers for the past 1 year in a city like Gurgaon. So you'd think you're talking of tier 2, tier 3 cities. I'm talking of Gurgaon. Sadly, for cancer, there are three cancers they're looking at. They're looking at oral cancer, they're looking at cervical cancer, which is the cancer of the mouth of the cervix, and they're looking at breast cancer. So when I spoke to these ASHA workers about what they do when it comes to these cancers, for oral cancers, it's very easy to train anybody and to counsel. अगर आपके मुंह में आपको घाव दिख रहा है, it could be something. अगर वो 2 हफ्ते में ठीक नहीं हुआ, go to a doctor. Very simple to say that. They do that beautifully. For cervical cancer, they're doing something called the VR testing, in which they use a little chemical called acetic acid, and they look for changes in the mouth of the cervix. They've been trained to do that beautifully. So when I ask them, what do you do for breast cancer? So the lady tells me कि हम ladies को पूछते हैं breast में कोई दिक्कत तो नहीं है. अगर वो कहती हैं कि कोई दिक्कत तो नहीं है, मतलब they have nothing. They themselves do not know what breast self-examination is. No woman in the community is taught breast self-examination. And sadly, when you club the NCD program or give it to these ASHA workers who have maternal and child health, immunization, and now COVID, and then you throw this on their head, it is not going to work. So we definitely need from the government a separate, targeted, focused cancer awareness program, which is not clubbed with anything else, which is easy to do. And this cannot be done by the government alone. We have so many private players now. It has to be a collaboration. It has to be a public kind of an initiative where the private and the government hold hands to take this forwards in the community. Otherwise, this is not going to happen. And we can all sit and talk about improving screening in India. If in Gurgaon, 1 kilometer from Fortis, Max or Medanta, you cannot get a good screening mammogram done, then obviously we need to do way much more in tier 2 and tier 3 cities. And we as the common population need to fight to get that. And as Dr. Vedant mentioned, if in COVID times, even an uneducated person could talk about the difference between the different type of vaccines that were available and have an intelligent conversation about that, that in your face awareness campaign about cancer is the need of the hour. And if we don't understand it, 10 years down the line, the landscape is going to be really sad.
You just need to compare the mortality of COVID and that due to cancer and preventable cancers. Just preventable cancer and other diseases. Just take, for example, tobacco. Kills many more every year as compared to total COVID mortality.
Your views on bringing these to tier 2, tier 3 cities?
I agree with both the panelists here that there's so much more that the government can do, because private sectors can go out and do it, but it's more the government that has to be involved from step one of awareness, education, etc., and then bring out other screening techniques. But there was one more point that I actually wanted to ask the both of you as well. Today, there's so many diagnostic centers or private owners who just go out saying that there are these new devices called the Braster, right? Predominantly thermography, and it's even there in a few corporate hospitals. I per se do not let anyone with thermography enter the hospital because I don't believe in it. What's your view on this?
So I did have a little bit of a run with thermography, and we did do, I think, around 400-500 thermography tests. So see, when you couple it with AI, as is claimed by the company, whether it works better or not, I don't think I am still fully convinced. But my take on this is, if a woman is willing to come forward to do a thermal screening, if just that is helping bridge the barrier between I will never go for a breast screening because I don't have a problem, but coming to do at least something when she doesn't have a problem, understanding that you need to do a screening test when you don't have a problem, and if that helps bridge it to take her to the next step, which is go to a doctor when you have a problem, get a screening mammogram when you have a problem. I don't know whether it does help work in that space, but yes, it is not a standard of care as of yet, and we cannot, condone,
Yeah, we cannot propagate or promote it as a standard of care. So I would agree that as a bridge, yes, but that woman needs to know that this is not the standard of care. You know, how many people are actually telling her this?
I asked you this question because nowadays in tier 2 and tier 3, they're taking the thermography devices there to get it done.
Even Punjab government is now doing a little program with them.
Whether AI or no AI, it has to stand the test of scientific scrutiny, and then yes, we can use it.
And I think we also need to mention that screening mammograms can also miss up to 10% breast cancers. Yes. So, if you go and get a mammogram and it's normal, but you still feel a lump in your breast, please make sure you get it checked out.
Dr. Kabra, this is my last question, and I want to address it to you. What are your views on mammogram screening and the kind of age, right? Age.
What do you recommend?
So I agree with Dr. Kanchan. We should start at 40. In our country, we must start at 40. No doubt about that. We have to be very careful. She said 10% can be missed on mammogram. So if the lady has a symptom, it cannot be ignored. You have to find a cause for that symptom. You have to find if there is a lump or if there is a nipple discharge, what is causing that nipple discharge. If it requires another mammogram, a better mammogram, an ultrasound or MRI, I think we have to go ahead and do it. And age, I think 40 years.
Yours is 40, right?
Yes. That's a difficult question
I
to
think
answer.
that is
very difficult
one
question
thing
to
that
answer.
we need to three of you can suggest for each for your own.
We will not come to a consensus.
So I'll tell you what I am telling my patients right now. Between 40 to 50, every 1 to 2 years. So I'm putting that 1 year also there, and after 50, every year.
I say the same
You're
to my
taking
patients.
a comfortable stance.
I say the same.
And regarding the upper limit of age, again there is no consensus. I think a fair age is probably 75. A lady who is very healthy at 75 has a life expectancy of more than 10 years. I think she should continue beyond 75.
Agree.
Last 1 minute, from three of you, I want to understand, are there any preventive measures that women can take in their habits, daily habits that will do, so we do, because we clearly don't know the actual cause of it. So I don't know what preventions do you
So you said it yourself. We don't really know the actual cause of it. So if you don't really know the cause of it, you can't really have a prevention. But having had said that, breast cancer or most cancers are lifestyle diseases. And lack of exercise and not having the right kind of eating habits contribute to a large amount of cancers and probably to breast cancer as well. Alcohol consumption is being linked more and more to breast cancer risk. And I know our Indian women are taking up onto alcohol in a very big way. So a little word of caution there. And self-awareness and picking up any lump or any changes in time is the biggest protective and in a way preventive factor There are theoretical things about having kids in time, breastfeeding, but then you cannot tell an educated woman today who's trying to progress with her career to have her kids under the age of 30, to have 4 or 5 kids, breastfeed them all, you know. So those are the kind of things which are not always that practical. And also very, very importantly, for those who have a strong family history of breast cancer, like Dr. Vedant also just said, if there is a strong family history of breast cancer, please don't act like the ostrich with your head in the sand thinking, mujhe nahi hoga, it won't happen to me. So if you have a strong family history of breast cancer, please be more proactive, because there are definitive preventive steps that can be taken then in the form of risk-reducing surgeries.
Right.
So just to put this in perspective, in 1900, the mortality in US, 2/3 was because of infection-related diseases. In 2000, 2/3 was because of lifestyle diseases. And cancer is one of the very important lifestyle diseases. Breast cancer also has lifestyle elements. So alcohol, she has mentioned. Tobacco has not been yet proven to have a direct link, but it has linked to many other cancers, possibly also to breast cancer. And if tobacco and alcohol both are combined, it is a synergistic effect. She also mentioned about hormonal changes which happen during pregnancy and breastfeed. There is another very important aspect. As you delay the pregnancy, and otherwise also, infertility is also rising. Then you resort to IVF, which has very strong hormonal stimulation cycles, sometimes multiple times. We don't know what it causes to development of breast cancer. I have had at least 2 or 3 patients recently in last couple of years. When I checked with them what they are consuming, they were taking supplements, and multiple supplements having soy products. These are estrogenic products. Again, we have to be very, very careful in what we are consuming. And lastly, I think health is not only physical health. We have to see it in a holistic way. It has to be a physical, mental, and spiritual, everything combined, which I feel very strongly not only prevents cancer, also helps in getting better tolerance to treatment and preventing recurrences.
I wouldn't add much more than what they've already mentioned.
Right, right. So getting to an awareness level of COVID, as Dr. Kaur mentioned, and and getting these mammograms or top class gold standard detection methods in our tier 2, tier 3 cities, and in cities like Gurugram. But firstly, foremostly, there should be aware clinical practitioner should be present, and more awareness among our medical workforce then the public first needs to take place. Thank you so much for joining us here, all our panelists. Thank you so much, audience, for listening. We have a question.
I wanted to check, all of you at some stage in your discussion today have talked about the need for a patient coming to you needing counseling, needing awareness, needing a lot more than just a diagnosis. How much of that are hospitals like Medanta, Fortis, AIG, bridging the gap when you have captive audience with you in terms of patients coming to you? How much of that is being holistically addressed? Dr. Vedant just mentioned, mental, spiritual, physical parts that need to be addressed. Is that something that hospitals like yours are addressing along with diagnosis and treatment?
As far as AIG is concerned, yes, we have a one-stop breast clinic where every single patient, obviously when they come in with any symptom, not only do they get the biopsy, etc., and get the diagnosis, but then there's both pre-biopsy and post-biopsy counseling that the patient undergoes. And there's also the awareness part of it. If there's any patient who just walks out with, they just come for a mammogram or any symptom, every patient is taught breast self-examination and the need to come back for a clinical breast examination. Again, this is one hospital, and I would believe that this will take off if every single hospital believes in extensive amount of counseling, more so in those people with a strong family history, because like Dr. Kanchan mentioned earlier, if you actually take the necessary measures, you can prevent it in those family history, patients with the family history.